Topbed Talk.
So our final speaker is Steve Evans, who's our CPOC fellow. Steve's an anaesthetic trainee. Last time I introduced him, I said he was an ST4, he's an ST7, but he's an anaesthetic trainee down in the Southwest, and he's going to give us a bit of an update on some of the occurrences in education and training.
Thank you very much, Dave. So hello, good morning. My name is Steve Evans. I am an anaesthetist in training and the Centre for Perioperative Care fellow, and I'll be spending the next 10 minutes or so talking to you about perioperative care, education, training, and an exciting and ambitious project which CPOC is developing. So before I start, I just want to ask some questions to you, really, just questions just to ponder in your own mind. These are quite big questions and I don't really have the answers to them, and we've kind of touched upon a couple of topics already. So what is a perioperative specialist? You know, there are lots of people in this room who specialise in perioperative care. We've heard that it's from the point of contemplation of surgery through to full recovery. And that's quite a big pathway to specialise in, really. Or should we be saying perioperative generalists? We heard a little bit from Lawrence. So what does the patient expect when they see a perioperative specialist? Who are they seeing? Are they seeing a primary care physician, a GP? Are they perioperative specialists? Or a physiotherapist or a nurse? Or should there be someone who is overseeing their entire perioperative journey whilst they're an inpatient and coordinating their care? And what does the ideal perioperative specialists look like? What training do they have? What postgraduate training do they need? Do they need to have specialist interest in acute or general medicine, elderly care or surgery? And does all of this require a bespoke training pathway? And taking all of this into consideration, who is currently best placed to provide this? This is the latest figure I've taken from the Office for National Statistics. 3.1 million patients or people in the United Kingdom will be aged 85 or over by 2050. And as a proportion of the population, that's about 4% of the population, double what it is now. There's a changing age structure with an increasingly elderly population, and we'll be seeing more and more people live to age 100 years old. This graph probably highlights what we're all going to be dealing with over the course of our careers. There's age on the x-axis from 0 through to 85 plus, and the percentage of patients on the y-axis. And the change in colour from the top left and the kind of a light blue down to the bottom right, the dark blue, represents the increasing number of disorders or comorbidities that patients have. About 50% of 50-year-olds will have at least one healthcare condition, and about 50% of 80-year-olds will have at least 3 healthcare conditions. And how we care for this increasingly complex group is challenging and will require a multidisciplinary approach. So what am I getting at here, and why is all this important? So back in 2013, here in the United Kingdom, Shape of Training Review highlighted this growing complexity of patient conditions with increasing health inequalities and changing patient expectations. The conclusion was that the workforce requires more generalists with broad-based training, and there was a key that they should have opportunities to train in new specialties or credential in specific areas. General Medical Council looked into their fitness to practice tribunals and concluded that the main reasons why a lot of doctors get into trouble is through deficits in their professionalism and communication. So they released their Excellence by Design programme, which set out standards for an evolving and new postgraduate curriculum. And Health Education England in 2020 released their Future Doctor programme, which again highlighted and emphasised a patient-centred approach with personalised care, and that we should be practising in a way to meet the local population needs. And all of this was embedded, again here in the United Kingdom last year, into the adoption of new postgraduate training pathways. And this is the generic professional capabilities framework which underpin a lot of the professional practice which we do. Again, a focus on generalists as opposed to specialists. And overlapping all of these changes to the postgraduate curriculum, the Royal College of Anaesthetists released this in 2014 with the aim of promoting best perioperative practice to reduce variations in care. And in order to support this implementation, there's been widespread changes in both education and training. There's been a shift from this siloed approach where we should be putting the patient at the centre of what we do and wrapping around this number of perioperative specialists. And the anaesthetic curriculum in the UK has widely embedded this, and it forms a significant part of training, but there are some discrepancies with some of our other Royal Colleges. There's been lots of other achievements. There's been the Perioperative Leads programme, which is lots of perioperative specialists within hospital departments. We've got the National Perioperative Quality Improvement programme. There's a greater emphasis on shared decision making, which was touched upon, and this is now embedded into General Medical Council guidance. And again, we heard a lot from yesterday about the prehabilitation and promoting exercise, smoking cessation, and an emphasis on turning these waiting lists into preparation lists. And there are similar approaches abroad as well, and I'm aware that there was a perioperative surgical home program which has been set up by the American Society of Anaesthesiologists. Again, this is a patient-focused approach to improve care. Now, this survey caught my eye, and it's something I'd been thinking about before I actually read it, really. And in total, there's about 760 responses, which is a proportion of the UK anaesthetic population is actually relatively small, but it still does provide a little bit of useful information. About 64% of respondents considered themselves to be a perioperative doctor, and about 44% believed that anaesthetists should be involved until there's a no acute postoperative issue, as opposed to until full recovery. About 3/4 stated that anaesthesia is best placed to provide perioperative care, but paradoxically, about 40% didn't want to practice perioperative care. About 2/3 believed that this could be delivered by elderly care physicians, and about half of respondents believed that intensivists, surgeons, or physicians would be best placed. About 1/4 felt confident in actually optimizing medical comorbidities, and about 50% felt they would benefit from further clinical exposure. Now, this, also taken from the same survey, was actually very interesting as well. And it talks about the nature of post-operative ward reviews, and wanted respondents to think specifically about the last post-operative patient they saw on the surgical ward. Now, just a little show of hands from the top one here. Social interaction as a courtesy to the patient I'd anaesthetised. I'm guilty of that. Other is an analgesia review, and the rest of it, fluid balance, a complication, early warning score, post-operative delirium. I mean, this is all something that we would do, you know, in the immediate, early and post-operative period, but often, and again here in the United Kingdom, a lot of the complexities of this post-operative care is often taken up by more junior members of the team on the ward. Now, this next question is a little bit provocative, and I'm very aware of the audience that I'm pitching to, is, you know, are anaesthetists truly best placed to deliver and pave the way for perioperative care? Should it be physicians? Should it be surgeons? I don't really know the answer to this. Or should it be, no, we should all start to work together a little bit more? So what are we trying to do here at CPOC? Just moving on. So we're in the process of developing and designing a multidisciplinary perioperative qualification. This will be a formal recognition of expertise in specific areas of perioperative practice, which will be devised, delivered, and recognised by registered bodies. This will be focused to a particular area of need and allow for flexible practice outside of normal clinical practice. Ideally, we'd like to start with a postgraduate medical workforce, but ideally extend this to allied health professionals, so for example, nurses or physiotherapists. And this aligns with a number of national initiatives to create a flexible and generalist workforce, and one which should complement the current training pathways. Upskilling of our allied health professionals would provide increased knowledge and autonomy, and should provide a greater degree of workplace satisfaction. A couple of years ago, the Centre for Perioperative Care did some rapid research reviews which showed overwhelming support and evidence that perioperative care works. The multidisciplinary working in perioperative care on the left-hand side teases out some of the essentials of successful team working and identifies some of the barriers and enablers. And it highlighted that there was some evidence that multidisciplinary working can speed access to surgery, improve patients' clinical outcomes, and reduce surgical care costs. Some of the perceptions to perioperative care was generally positive, and patients and professionals supported the principles of it, but how this was going to be implemented and by who were some of the big questions. And the impacts of perioperative care adds weight to existing and evolving evidence that it can reduce the amount of time spent in hospital, reduce the use of intensive care units, and hopefully reduce some costs as well. And we've discussed with and taken inspiration for our evolving perioperative curriculum from three main groups, really. Here, the Faculty of Pain Medicine have already started their credentialing process, which is part of a GMC credentialing process. And the idea is to give access to high-level knowledge, complements the training pathway, and enhances and enriches their current practice. And they've seen pooling of people coming in from other backgrounds, so for example, rheumatology, neurology, and palliative care, who want to credential in pain. We had a very useful and collaborative meeting with our colleagues in Australia from the Australian New Zealand College of Anaesthetists, who have already developed a perioperative credential curriculum, which is a one-year flexible-based diploma, done over 6 modules, initially for a medical workforce and due to be rolled out next year. And the multi-professional framework for advanced clinical practice in England is a Health Education England delivered framework to deliver innovative models of care for advanced clinical practitioners. And these are healthcare professionals that can practice at high levels of skill and autonomy and foster new ways of working, and it helps to empower the workforce to adapt and meet the growing needs of our population. And as Jagdeep mentioned, the advanced clinical practice for perioperative medicine for the older patient is a fantastic example of how this can be achieved. So what are we trying to do? Are we trying to create this mystical perioperative specialist? This all-knowing, all-seeing individual who's good at everything? Or as this light-hearted image shows, are we just trying to create a platform where patient and people with an interest in perioperative care can formalise their interest and knowledge, and through practice and experience become experienced in patient care? Not only will this be of benefit to the patient, but will help to create a generalist and flexible workforce to meet the growing needs of our system, and also for individual development, for future-proofing careers, job satisfaction, and hopefully better job retention. So we started this process a couple of years ago, and our proposal was accepted by Health Education England in the summer of 2020. We started working on drafting the outline in summer last year. We had extensive meetings in autumn last year, which involved meetings with the Faculty of Pain Medicine. We had a meeting with our colleagues in Australia and New Zealand, which will form a large kind of international collaboration. And in spring of this year, so just a couple of months ago, the prior information notice, or the PIN, was issued to CPOC from Health Education England. And now we're currently in the process of formalising this and deciding how to take it forward. So overall, we feel that the development of this credential aligns with the need for a flexible and generalist workforce, skilled in communication, leadership, and multi-professional team working. And what's next? We're about to appoint a chair for the group, the formation of a working group, can either be a core and a wider group, involvement of key stakeholders, and very importantly, again, as Lawrence has mentioned, we wanted a patient involvement and patient group right from the very beginning of this, because that's ultimately who we're doing it for. Governance is going to be a bit of a sticky subject we need to kind of tease out, and the idea we're going to get started on this later this year. Thank you very much for your time.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.